Hello, my name is Jonna Carla Dunlap. Today I will be presenting on gambling disorder. According to the DSM-5-TR, gambling disorder is characterized by persistent problematic gambling behavior leading to significant impairment or distress, requiring at least 4 symptoms within a 12-month period. Some of the key symptoms include increased need to gamble, irritability when attempting to stop, preoccupation with gambling, gambling to relieve stress, and lying about gambling involvement. Severity is classified as mild, moderate, or severe. Remission is categorized as early as 3 to 12 months without meeting criteria, or sustained 12 months or longer without meeting criteria. The gambling behavior must not be better explained by a manic episode. Gambling disorder, or GD, has a significant prevalence among diverse populations. Ethnic and racial minorities often experience higher rates of GD compared to non-Hispanic whites. GD prevalence varies widely among minority groups, ranging from 0.03% in Hispanics to as high as 58% in Southeast Asian refugees. African American adolescents show high rates of gambling problems compared to non-minorities. Southeast Asian refugees in the U.S. have a lifetime GD prevalence of 59%, which is 25 times higher than the general population. Some studies show Native Americans exhibit elevated GD rates with 10% lifetime pathological gambling. Impact of GD in minority populations is multifaceted, influenced by various factors. These include socioeconomic factors. GD is associated with gender, age, marital status, education, and income levels with variations across racial and ethnic groups. Comorbidities. GD is extremely linked to substance abuse such as alcohol, tobacco, and marijuana, and psychiatric conditions like depression, PTSD, and impulsivity. Cultural influences. Cultural values and beliefs shape gambling behaviors. For instance, gambling is normalized in Chinese social events and condemned in Muslim cultures. Cognitive biases like the gambler's fallacy are more prevalent in certain groups such as Asians. Asians are more prone to believing that something positive will happen after a run of bad luck. Stress and discrimination. Immigration-related stress, unemployment, language barriers, and social isolation can increase vulnerability to GD. Discrimination has also been linked to GD, with studies showing that racial discrimination can lead to gambling as a coping mechanism. Acculturation is also a process that can influence gambling behaviors. First-generation immigrants tend to have lower rates of GD compared to second and third-generation immigrants, who are more exposed to gambling in host cultures. Treatment challenges. Despite the high prevalence of GD among minority groups, treatment-seeking rates remain low across all populations, with only 9.3% of individuals seeking help. Some of the barriers include cultural stigma, distrust of mental health providers, lack of culturally tailored services, and fear of deportation among undocumented immigrants. There is a pressing need for targeted intervention research to address the unique challenges faced by these groups. There are some brief screening tools to assess GD, including the Lie-Bet Scale Questionnaire, South Oaks Gambling Screen, or SOGS, and the Gambling Disorder Identification Test, or GDIT. The Lie-Bet Questionnaire is a screening tool used to identify individuals at risk for gambling disorder. It consists of 2 items. It is brief, can be used in various settings like primary care and mental health clinics, as well as addiction treatment programs, and screening sensitivity is 100%. The impact of selecting this tool and some of its advantages include its simplicity and efficiency, high sensitivity, its versatility and used in various settings, its focus on key indicators, the ease of interpretation, anonymity and accessibility, as well as applicability to adolescents and young adults. The simplicity of the tool makes it suitable for younger populations who may be less likely to engage with lengthy or complex assessments. The South Oaks Gambling Screen, or SOGS, is a widely used screening tool designed to assess the possible presence of gambling problems. It was developed by Lizier and Bloom in 1987, consisting of 20 multiple choice questions. The SOGS can be administered by professionals, non-professionals, through the computer or through self-administration. It has been adapted and validated in various languages and cultures, demonstrating good psychometric properties. However, it has been criticized, such as for its high rate of false positives. Another screening tool is the Gambling Disorder Identification Test, or the GDIT, which is a self-report measure designed to assess gambling behavior and identify GD based on the DSM-5 criteria. It consists of 14 items divided into 3 subscales: gambling behaviors, gambling symptoms, and negative consequences. The GIT has demonstrated strong psychometric properties, including high internal consistency reliability and test-retest reliability. It is suitable for use in both studies and clinical settings to detect and assess GD, including its severity. Additionally, the GDIT's time and frequency-based response options allow for precise measurement of gambling patterns, making it a valuable tool for monitoring risk levels and assessing the impact of interventions over time. There are also more comprehensive assessment tools for GD, including the National Opinion Research Center DSM Screen for Gambling Problems, or NODS, the Gambling Pathways Questionnaire, or the GPQ, and the Problem Gambling Severity Index, or the PGSI. NODS is a standardized screening tool designed to assess gambling-related problems based on the criteria for gambling disorder outlined in the DSM. It consists of 34 questions, with half focusing on gambling behaviors in the past year and the other half addressing lifetime experiences. Responses are binary, yes or no, with yes indicating gambling problems. The total score categorizes individuals into 4 groups: low-risk gambler, at-risk gambler, problem gambler, and pathological gambler. Some of the advantages of NODS include its alignment with the DSM criteria, validated versions, including a lifetime assessment, categorization of gambling risk, and its good reliability and validity. The GPQ is a validated 48-item instrument designed to detect membership in etiological subgroups of problem gamblers in clinical settings. It measures 11 subscales that assess various etiological variables of problem gambling, including mental distress symptoms, childhood maltreatment, stress coping motivation, meaning motivation, impulsivity, risk-taking, sexual risk-taking, and antisocial traits and behaviors. The impact of selecting this tool includes that it has demonstrated good validity and reliability with internal and consistencies of its subscales ranging from 0.74 impulsivity to 0.92 anxiety post-problem and gambling onset. It is used to assist counselors in individualized treatment planning by providing pathway classification and risk levels for each indicator. The PGSI is another comprehensive screening tool designed to measure problem gambling behavior. It consists of 9 items, each rated on a 4-point scale ranging from 0 to 3, with 0 being never and 3 being almost always. The total scores are summed to categorize individuals into different risk levels: non-problem gamblers, low-risk gambler, moderate-risk gambler, and problem gambler. The PGSI is widely used in gambling research to assess the severity of gambling problems and categorizes individuals based on their risk levels. The PGSI is selected for its reliability, ability to categorize gambling severity, and its alignment with public health goals. However, its limitations, such as the interpretation of risk categories, should be considered when using it in research or policy development. Ethnic minority groups often face barriers to seeking healthcare services for GD due to cultural stigma, language barriers, acculturation stress, and lack of awareness about available treatment options. To address these challenges, assessment strategies should incorporate cultural competence and sensitivity. This includes understanding cultural differences, It is important to recognize how different cultures perceive gambling and mental health issues, as some cultures may view gambling as a socially acceptable activity or associate mental health problems with shame. Adapting communication. We must ensure that language barriers are minimized by providing multilingual resources and culturally appropriate communication methods. Building trust. There needs to be a safe and non judgmental environment to encourage individuals from diverse backgrounds to seek help. Educating communities. Increasing awareness about available treatment options and reducing stigma through targeted outreach programs for ethnic minority groups is also important. Considering integration factors. For instance, adjusting assessments to account for citizenship and years of residency, as these factors influence health care seeking behavior and integration into the healthcare system. More key considerations when assessing individuals from diverse populations. Avoid assumptions. Practitioners must approach assessments without preconceived notions or stereotypes about a culture. Cultural humility involves acknowledging the limits of one's knowledge and being open to learning from the individual's lived experiences. Incorporate community resources. Many individuals from undeserved communities prefer seeking help within their own cultural or community networks. Assessment strategies should consider these preferences and involve community leaders, family members, or culturally relevant organizations. Understand socioeconomic and historical context. Factors such as poverty, trauma, resettlement challenges, and discrimination can significantly impact mental health and addictive behaviors. Assessment should account for these influences to provide a holistic understanding of the individual situation. And finally, focus on strengths and resilience. Cultural humility involves recognizing the strengths and resilience within communities. Assessments should highlight these aspects to empower individuals and support positive changes. Cultural factors play a significant role in assessing and diagnosing addictive disorders. Key considerations include cultural perspectives on gambling. Gambling may be viewed differently across cultures. Cultural beliefs and stigma. Cultural norms and values can influence attitudes towards gambling and addiction. Coping mechanisms. Negative coping styles such as gambling may intensify emotional distress, particularly during times of crisis. Financial motivation and materialism. Financially motivated gambling is a significant risk factor for addiction, especially among East and South Asian gamblers. Cultural values emphasizing material success may contribute to risky gambling behaviors, as seen in studies of Chinese gamblers. Family and community impact. Addictive behaviors can disrupt family and community dynamics, leading to loss of connection, shame, and stigma. These cultural harms should be considered in diagnosis and treatment. Mental health comorbidities. Mental health issues such as anxiety and depression are often comorbid with gambling addiction. South Asian gamblers, in particular, report higher levels of severe anxiety and depression, which may be influenced by cultural factors and coping styles. Awareness and access to support. Low awareness of responsible gambling information and problem gambling services, coupled with cultural stigma, may prevent individuals from seeking help. Tailored intervention that address cultural sensitivities and promote awareness are essential. Taking a look at American Indian and Alaska Native populations specifically. A study by Soto and colleagues examined substance and behavioral addiction in American Indian and Alaskan Native population. When assessing and diagnosing addictive disorders among this population, several cultural factors should be considered to ensure accuracy and cultural sensitivity. Historical trauma, the cumulative emotional and psychological wounding from colonization, forced relocation, and genocide has deeply impacted AI/AN communities. This trauma can manifest in addictive behaviors, making it essential to incorporate a trauma-informed approach in assessments. Cultural norms. Traditional cultural norms can influence addictive patterns. Understanding these norms is crucial for accurate diagnosis and effective intervention. Acculturation challenges. AIAN individuals often face pressures to navigate between their traditional culture and mainstream American practices, which can lead to stress and gambling as a coping mechanism. Cultural displacement. Forced relocation and boarding school experiences have disrupted family structures, cultural practices, and social networks. This cultural disconnection can contribute to addiction and should be considered during diagnosis. Cultural expressions of mental health. Variations in emotional and psychological expressions within AIAN cultures may not align with Western definitions of mental disorders. Mental health providers must be familiar with AIAN cultural practices to avoid misdiagnosis. Cultural resilience. Protective factors such as strong ethnic identity, cultural practices, and traditional healing methods such as sweats, storytelling, use of sage play a significant role in promoting resilience and recovery. These should be integrated into the assessment and treatment process. Community and family dynamics. The importance of family and community in AIAN culture means that family gambling history, social modeling, and family conflict can be significant risk factors. Conversely, family cohesion, parental involvement, and cultural connections are protective factors that should be considered. Spirituality and healing practices. AIAN spirituality and traditional healing practices are central to their well being. Incorporating these practices into the assessment and treatment process can enhance engagement and outcomes. By considering these cultural factors, healthcare providers can offer more accurate diagnosis and cultural appropriate interventions that respect and leverage the strength and resilience of AIAN and other culturally diverse communities. Thank you.